So I realized I didn't introduce myself, but my name is Peter Pang. Welcome to Indianapolis. Actually, this is home for me. All right, and in case any of you are wondering, like, what happened to my wrist, I will just tell you, in case any of you are concerned, is this was the faculty resident kickball game, okay? It wasn't anything fancy or anything else like this. I dropped the ball, then I fell to the ground, and I injured my wrist. That's the reality of what happened. But I will tell you, we won, all right? So for any of you that did it, we won, all right? So briefly, what I'm going to talk about here is just some of the ongoing studies that we have. So we set the stage a little bit with the background. What have we learned from some recent trials? I'm going to talk about some studies that we currently have ongoing, and then Sean's going to finish up with what are some unanswered questions that we have. These are my disclosures. So congestion is not good. We don't really call it congestive heart failure anymore because lots of patients have heart failure and walk around and actually aren't congested. But that's the traditional way we talk about it. A patient has a CHF exacerbation. So we know congestion is bad. But interestingly enough, what do we target when we try to decongest patients is actually a matter of controversy. Right, so all of you probably remember being on wards or rounds. We got to measure urine output or eyes and O's. We want to look at body weight. We do jugular venous pressures, listen for S3s, measure lower extremity edema or sacral edema, are all ways that we look at congestion. But surprisingly, actually, there's no uniform consensus on what's the best way to measure it. So we know it's bad. We know if you don't decongest, that's bad. But we haven't agreed on how we should measure it in order to improve the outcomes for patients. We just know that it's bad. Right? But actually a universal algorithm doesn't exist. Now, there are some strong opinions, and we definitely do things every single day for patients that we manage, and I'm not saying those are wrong, but I think it's worthwhile to point out actually the science behind this or a well-validated universal way that we look at this doesn't exist. And that's essentially one of these scientific statements here, essentially at the bottom. So one way that was mentioned that we would look at, and this is a slide that I've stolen from some of our ultrasonographers, actually it's one from Italy, but these are showing some B-lines for those of you who are good at ultrasonography or better than I am. And as mentioned before, this is a potential target for congestion. What we proposed, right, is that in addition to clinical signs and symptoms, what if we go after B-lines and see if we actually use this as a target? So for those of you who know this area, we know it helps with diagnosis. We know it's a prognostic marker, but we don't know if it's actually a way that we could potentially mediate therapy, right? So in other words, we know it's bad, but does moving this number actually equal better? That's the question we don't know. And that's the purpose behind this trial. It's an NIH-funded study. It's a clinical pilot trial grant. So the whole purpose is actually to give us the preliminary data to go for the R1. This is something that we're working on together called the blushed AHF study, where we'll target B-lines. Another question that's been brought up earlier in the talks is, does anyone with acute heart failure go home? So as we saw before, we admit almost 85 to 90% of these patients. Right? And this is remarkably consistent over the period of time, despite efforts to try to reduce 30-day readmissions. Right? One of the reasons why is because for all of you that take care of these patients, they look sick. And as emergency care providers or acute care providers, we haven't seen these patients before. So to us, they look sick. Maybe if we had seen them every single day, they may look relatively stable. But probably this is one of the reasons why we admit these patients. They're older. They have multiple comorbidities. They're on multiple medications. And we know actually their outcomes are bad. Actually, their outcomes aren't as bad in the short term, but they worry us enough where we generally admit these patients because we actually lack robust risk stratification tools for these patients, unlike ACS or chest pain, where we have quite a few. So this is something I've always stolen from Sean, and I actually see Alan in the audience as well, is that we know, and oftentimes this happens when we try to admit patients, is just because they don't have these clear high-risk features doesn't mean they're low risk enough to be sent home, right? It just means they're not high risk. What truly equals low risk or low enough risk to send them home? And this is an example of this that comes from a Canadian data set. It's a modeling paper, so not actually a prospective study, but what's really interesting is that our gestalt appears to be bad. If we send patients home out of the ER, their actually outcomes are worse than patients who are admitted. In other words, we choose poorly, all right, in terms of how do we differentiate risk, at least with our current existing risk instruments, which really aren't that well validated, though there are some good ones that have come out that just need further study compared to how we actually just look at patients with a gestalt. So what we proposed and got funded from the Agency for Healthcare Research and Quality, and this was a 10-year effort and built on the work of quite a few people in this room and on this panel, is called the Short Stay Unit Acute Heart Failure Study, funded by ARC. And what we're going to do actually is what's missing from this observation unit study data is essentially to say, as a randomized controlled trial design. So for most of you that follow this literature, we know that observation units actually work for heart failure. But what's been missing is the study design. They tend to be either retrospective cohort studies or observational cohort studies or just looking through chart review or claims data, but we're actually missing the randomization for this type of patient group. So this is what we're going to do. It's been going on for about 6 months. Actually, enrollment hasn't been great, and so I'm looking for a few more sites, and I've talked to some of you in this room about it, and so we're looking to expand this study further. But one of the reasons behind this is to show that we can care for patients for 24 hours and actually show that they don't have worse outcomes. I think that will give us some reassurance that we can perhaps start to send these patients home. For those of you who have practiced long enough, you remember when all these chest pain patients got admitted. And then we did chest pain decision units or observation units where we started to stress test all these patients. Now we don't even do that. Now most actually go home, and we have the moderate risk patients that we're only putting into observation unit. And even then, we're not even doing functional testing for many of those, depending on your institution. And that's what at least we're trying to see to set the stage and groundwork for this future work. This is the flow diagram. And then one issue here that's important is that the initial plan has to be to admit the patient for the study. We can't take patients going to OBS and put them inpatient. They've got to be planned for admission, and then we're randomizing at that time. And our primary endpoint, essentially looking at days alive and out of hospital and some quality of life endpoints. And this has been a very good partnership with the School of Nursing here at Indiana University. So this is a study funded by PCORI when Sean Collins is the PI. So this is the study actually looking at transitions of care. And perhaps this is another reason, again, as emergency physicians or acute care providers, why we're hesitant to send patients home, is what happens to them. So actually, it's our understanding of what happens to patients discharged from the emergency to heart failure is remarkably low. One reason is because most patients get admitted. But then once they get discharged, there's actually no real robust database to try to follow up on these patients. As you can see from this slide, which I also stole from Sean, but it was actually originally published by Oscar Moreau out of Spain, is if you look in this red box, what you see is this importance of post-discharge planning or transitional care. Right? Everyone agrees this is important, but how should we do it? And then is there something special or unique that we should do for these patients, especially if they have heart failure with all these comorbid conditions as they leave the emergency department? So this PCORI-funded study, again with quite a bit of significant input from patients, will look at a transitional care program, more intensive transitional care program versus usual care. And we'll get a look to see whether or not this will aid us in our decision-making to try to discharge patients from the emergency department. This is the kind of rough study design here. Again, they have to plan to be discharged from the emergency department or after a brief observation stay, so identifying a lower risk cohort. I think we're about 300 patients in, 400 patients in. So another study on kind of risk stratification, and I don't know where I am time-wise. Close. So this is the TACIT study. This is an investigator-initiated study by Roche. And the premise behind this was similar to what Phil showed with these curves for high-sensitivity troponin. So for all of you that are following this, right, it's only recently approved a single assay. It's Roche's assay, actually, in the United States, though it's been around in Canada, Australia, and Europe for almost a decade. But this was a secondary analysis that we did out of the RELAX data set. And if you look on the bottom line, essentially what this shows is for patients who do not show evidence of troponin release or myocardial injury, they actually had no deaths through 180 days. None. Right? Now, it's a retrospective analysis. It has all its limitations for doing a retrospective analysis. But not surprisingly, those patients are lower risk. They didn't have evidence of myocardial injury. They were at lower risk for adverse events. And all of you see this, right? You see patients who clearly have heart failure. They don't have acute coronary syndrome, but they have some evidence of myocardial injury. What happens? So again, at least for this study, from a mortality standpoint, this was interesting, intriguing, and hypothesis generating. Again, no deaths through 180 days. And we use the MI cut point. We use that just because it was a standard, but we don't know what the cut point is in acute heart failure. Right? So we just chose the MI cut point. So the TACIT study was a prospective observational cohort study, and essentially what we wanted to do was to see what happens if you do or don't have troponin release on a serial blood draw over 3 hours in patients who present with acute heart failure. Sample size was 500 patients. We actually finished this enrollment in November after quite a bit of work for the sites that were involved. We just completed 90-day follow-up, and we hope to report this out by the end of this summer for those top-line results. Finally, this is my last slide. I want to give a little plug for what some of you have heard is the MROC network. You know, we have worked together for almost a decade. It's interesting to sometimes reflect on where we started from and where we are, and we've had some losses, some failures, some spectacular, but I think we've had also our share of successes and some wins as well, and it's been fun. And also, these are some of the funding agencies that we've gone to for the studies that we work with. And again, you know, hopefully there'll be a chance to partner with some of you again in the future. So thank you for your time.